Thank you very much. So I realize we're running a little bit behind time, so if it's okay, I will scoot through this. The fundamental question I want to ask is, are we missing opportunities to implant appropriate deceased donor kidneys into children and young people? Being very careful about my use of language there. What I'm going to talk about today is the outcomes in pediatric renal replacement therapy. There will be many people in the audience who know more about that than I do, but just to set the scene, I'll be talking a little bit about how we assess deceased donor kidney quality and what risk means from a surgical perspective. I'm going to be asking some tough questions about how good our organ utilization decisions are and whether we could be any better, and a few further issues to touch on at the end, and perhaps a suggested approach as well. I'm also aware that there are a lot of people in this room who may have experiences not just in different centers, but in different countries as well, and I suspect that every country and every center has its own challenges in this regard. So, this actually shocked me, I must say. I looked at the UK Renal Registry for the outcomes of children incident on dialysis stratified by age. And although the scale on the left there is slightly magnified from 80 to 100%, if you start dialysis as a 0 to 2-year-old in this country, after 10 years, your survival is only 85%. I feel very privileged as a surgeon. I don't have to deal with the outcomes of that. It's my pediatric nephrology colleagues who talk to parents, who talk to siblings and explain the implications of that. But for me, that is the essence of the surgical decision making that we are faced with at the time of organ offering. If we don't transplant these children, this is what their fate may have in hand for them. If we look at the survival hazard ratio in children who are on dialysis versus being on transplant, this is slightly old data. Apologies, I couldn't find anything newer. But you can see at the bottom there, being on dialysis has a 7-fold higher risk of mortality. The risk is still relatively low compared to other pediatric diseases, and I have colleagues in the audience who may be familiar with liver failure. We heard a great talk of the risk of dying on the waiting list. But for those of us in the kidney transplant world, they're very humbling data to be aware of, and that's why we want to get our patients off dialysis in an appropriate way. Of course, there are differences in terms of transplant options. In an ideal world, all of our children would have a living donor from a healthy and fit and well mum or dad or grandparent or cousin or perhaps even sibling if they're over 18. The reality is, certainly in London and in many other places around the UK, those parents may have other children with renal failure. They may be struggling with health issues themselves, and therefore it's obviously appropriate for the kids to be on the deceased donor list. Great to see that DCD outcomes are as good, if not better, than DBD. Again, this data is perhaps slightly old now, but certainly minimizes some of the concerns that we might have had in the past about DCD outcomes in children. So when we're talking about kidney quality, and we're just focusing on deceased donors now, not living donors, what do we mean by risk? And I've divided this from a temporal perspective, so from short-term and long-term, and then other risks, particularly around the risk of transmission. If we talk about short-term graft function, I guess we're really talking about delayed graft function and primary non-function. Delayed graft function in this hospital, in Guy's Hospital, happens all the time. 50 to 60% of our adult deceased donor kidney recipients will have delayed graft function. It doesn't bother us too much. It might be for a week, it might be for 2 weeks or 3 weeks. We start getting a little bit twitchy at that point. It's not too bad. If I was at the Evelina or GOS, DGF is a different kettle of fish entirely. Far harder to manage a child post-transplant with DGF, both physically and psychologically. But in the long run, the impacts are probably fairly minimal for DCDs. For DBDs, there may be slightly more risk. If we look at donor AKI and the impact on delayed graft function, which I think often worries us when we're on call taking organ offers, we can see that for deceased donors up to AKIN stage 1 or stage 2, the risks are certainly slightly higher, but not excessively so. This is primarily taken from adult population. When we get to stage 3, however, the risks are higher again. and we start to worry about primary non-function. And just so people are aware, primary non-function is the kidney never working. Delayed graft function means that it does work at some point. Again, we can be relatively happy with donors with Aiken stage 1 or stage 2. The odds ratios are not increased there. You can see that on the left-hand side. But data from Kat Boffa's work from Oxford and Portsmouth suggests that Aiken stage 3, there is an increased risk of PNF, approximately 2 to 3 times. And I think we would be appropriately cautious in our paediatric population. Really, I want to focus much more on long-term graft function. That's what we really hear, what we worry about, and what we're here for. And a lot of people will still be thinking about SCDs and ECDs, so standard criteria donors, extended criteria donors. If I could really ask you to try and throw away that terminology, I think it's distinctly unhelpful. Trying to distinguish things in a binary fashion, good and bad, ECD, SCD, is, I think, oversimplistic, to say the least. Risk is a spectrum, and we're very fortunate that in the modern era we have appropriate donor risk indices to allow us to explore that spectrum. So I think SCDs and ECD terminology should be discarded. There's lots of different donor risk indices. We can go to the US, where they have lots of data, and they have very complex risk indices. In the UK, we like to keep things a little bit simpler. This is work from Chris Watson and Andrew Bradley in 2012, and they did a retrospective analysis using the UK transplant registry, and only 6 or 7 factors had an independent impact on graft survival. This is modeled in adult recipients. By far the strongest donor risk factor for poor graft outcome in the long term is donor age. However, there are other factors: hypertension, donor weight to some extent, hospital stay, and then adrenaline. If you ever want to publish lots of paper, get into the donor risk index world, because every 4 or 5 years you can just repeat the paper again because there's new data, so it needs to be updated. And Lisa Mumford, actually she hasn't published this, she's very naughty, she should do, reanalyzed UK transplant registry and updated it. And you can see the risk indices stratify into 4 different groups there, what have been described as D1, D2, D3, and D4. Donor factors, donor age, again, by far the most important factor, and there are other factors as well: height, hypertension, donor CMV, hospital stay, etc., etc. But really, 9 times out of 10, when I'm on call, what really bothers me is donor age, and I think at the moment our upper age limit for paediatric recipients in the UK is 60. That's recently increased in an effort to try and broaden the donor pool. The other thing that I mentioned that we worry about is transmission of serious diseases, and fundamentally that can be divided into 2: transmission of cancer or transmission of bloodborne viruses such as Hep B, Hep C, or HIV. So far as cancer is concerned, none of us are cancer experts on a day-to-day basis. It's not possible to carry all that information in one place. So we have these very accessible and easy to understand SABTO guidance. I'm being sarcastic, by the way. If you ever had to read through the SABTO guidance at 3 in the morning, it will probably put you to sleep if it wasn't for the fact that your phone was going off from the hub asking you to make a decision. The good news is we can get that information from the donor coordinators about the type of donor and get an estimate of the risk of transmission to the recipients. And you can see that might range to up to 6.5% all the way down to less than 2%. This information, as always, needs to be updated on a regular basis. But the fundamental question we need to ask ourselves is, what type of risk of transmission would we accept for a child on dialysis? A risk of 10% transmission, I would suggest, would be far too much. A risk of 5% still feels a bit much. A risk of 2% or 1%, I think we're starting to ask ourselves some tough questions. And why do I use those numbers? Well, we know the risk of the patient dying after a pediatric kidney transplant is in the region of 1 to 2% per year, or certainly for the first year or two after transplantation. So it's within that broad range of the risk of transmission anyway, and we can start to have sensible risk-benefit discussions. There are no clear lines or demarcations to say yes or no for pediatric patients. We are, of course, sensibly more conservative because our patients do have relatively low risks of dying, both on the waiting list and post-transplant, certainly compared to our liver colleagues. But it's about that type of threshold, 1 to 2% risk of transmission, that for me, I have in my mind as a cutoff when I'm thinking about the SABTO guidance. Transmission of serious diseases is just as concerning, but in some ways it's harder to get a handle on because there are more unknowns. We can get the donor stage, the grade of the cancer, the treatment that they've had, but the problem with deceased donation is that there are unknown unknowns. We never really know what the deceased donor has been up to in the last couple of weeks of their life. I don't know about you. I don't tell my GP everything that I do in my life. I'm pretty sure I tell my wife everything, but I'm not sure that would go for everyone in this room. So there is always a risk of transmissions of serious diseases. So if we have a donor that has negative hepatitis B, hepatitis C, negative HIV, but has increased infectious risk, which is actually identified, whether it be a prisoner or a sex worker, an intravenous drug user, that leaves us with a tough question to try and answer. We've got negative serology. Can we quantify the risk of that donor actually being in the window period and missing a transmission of disease, which is obviously upsetting for everyone? UK guidance around this is slightly less clear, partly because we have very, very few patients in this country who have HIV, Hep B, or Hep C, which is unrecognized. This is actually Canadian recommendations. I'll skip through this for the interest of time, but you can look up tables to say if they have negative serology, what is the risk of an unrecognized transmission, depending on the risk category there on the left-hand side. And using that information can start to give us an idea of whether we think that risk of transmission is acceptable or not. Broad rule of thumb, about 1 in 300. If you've got negative serology from a UK donor, but they have other risk factors, the chance of passing on something really nasty is going to be less than 1 in 100, probably less than 1 in 500, but I tend to use 1 in 300 as a ballpark. You can, of course, get NAT tests to reduce that window period even further, but you will never reduce it to 0, unfortunately. There's a whole different way of assessing kidney quality, of course, and this is something that nephrologists don't see because they don't get to pick up kidneys in their hot little hands. They're very welcome to come down to the theatre and pick up kidneys if they want, but there are all sorts of things that surgeons see, whether it be the perfusion deficit or scarring, damage at retrieval, cysts or patch quality. This is all important information, which might mean that as a nephrologist, you get a phone call from your surgeon saying, look, the numbers look great, but this kidney doesn't look right. I don't think we should go ahead. The problem is that is really difficult to quantify and assess. As a nephrologist, you would love a scoring system to say, well, okay, Georgios, that score's 6 out of 10, but I'm happy to go ahead because here's the risk estimate. We can't do that. We don't have the information and the scoring systems available to use, unfortunately. You may say, well, hold on, if there's some scarring there, perhaps we could do some pre-implantation histopathology. That actually causes a lot of problems. You have to wait for the histopathology. You have to have a histopathologist who's available at 2 or 3 in the morning. There are not many units that can do that. And it raises some very interesting questions about the predictive value of pre-implantation biopsies and their impact on long-term graft function. There are many different scoring systems out there. They tend to be, or they may be useful for older donors, over 60, over 70, with multiple comorbidities. I would suggest that the utility for pediatric kidney transplants is low, if not non-existent, because the organs you're getting offered anyway are pretty good, if not excellent. So we've got some problems there. Post-transplant outcomes are dependent on lots of different factors. The chronic donor risk indices, the donor risk indices I've just mentioned in terms of donor risk, in terms of donor age, CMV, and all those other things, actually have a fairly poor predictive value, a statistic of about 60 to 70%. There's a lack of evidence base for surgical decision-making and a lot of uncertainty about the use of pre-implantation kidney biopsies. So what can we do? Well, there are some predictive tools out there. In the interest of time, I won't spend too much time on this. Again, they're all focused on adults. The AID memoir can help in terms of defining risk of cancer. Fundamentally, I think we need to ask ourselves, are we as good as we can be, even with these uncertainties, in terms of making utilization decisions? And this is a funnel plot taken from the most recent kidney report for NHSBT, looking at the difference in offer decline rates between different centres in the UK Every dot there is a different paediatric kidney transplant center, and these are for organs which are ultimately implanted for standard criteria, DBD donor kidneys, and the variation around the country is marked. It's really huge. Some centers are saying no to 70% of kidneys which subsequently end up getting implanted. Some centers are saying no to just 20%. I think that poses some really tough questions for us as a community. We can't all be right and all be wrong at the same time. This is a great paper from Matko Marley and also from Steve Marks and colleagues from GOS, which basically asked that question. They looked at all those declined kidneys, declined for a pediatric recipient, and worked out what happened to the kidney if it was implanted and what happened to the patient that it was declined for. And in essence, if we focus on those kidneys which were declined for donor or size mismatch reasons for pediatric recipients, this is in 2009 to 2014, and work out what happened to that kidney afterwards, if it was implanted into an adult, had about a 94% 3-year renal allograft survival. That's pretty good. Strangely enough, if it was implanted into a child, the 3-year allograft survival was barely 80%, which I don't think any one of us would be happy with. I still can't quite get my head around this. I can't understand why some kidneys which end up going into kids would do so much worse than those going to adults. I suspect it's more of a reflection of the recipients. If a kidney has been offered to one child, turned down, then offered to another child, they must be very, very high priority recipients. They're probably highly sensitized with a lot of other medical issues. Fundamentally, I think a lot of those kidneys may well have been usable, but fascinating results and great work from the GOS team. As I said right at the start, it's really important to acknowledge that there are big variations between countries. Almost all of the information I've given you today has been based on UK data. If you're lucky enough to live in Denmark, Sweden, Finland, Slovakia, or France, your median waiting time for a deceased donor pediatric kidney transplant is about 6 months. If you need to, you can afford to be fairly picky. If you live in Turkey, Russia, Belarus, Netherlands, or Germany, very different. Your children are waiting for a long time. The risks on dialysis are starting to accrue. We are somewhere in the middle. Kind of makes it tough. We're neither Arthur nor Martha in this regard. So what should we do? We need to weigh up all the risks, all the pros and cons, think about our children on dialysis. What is their prognosis? What is their attitude to risk along with their parents and carers? What type of discussions have we had in clinic? How much risk are we willing to take as clinicians on their behalf? And actually, what are the risks? Can we separate short and long-term graft dysfunction and think about the risk of disease transmission? So just to summarize, I would suggest a decision-making framework. It's really important to distinguish between organ quality, long-term issues, and disease transmission. Disease transmission is usually easier to get a handle on, and the risks are fairly low. Please know the literature and your options. Please, please, please talk to the patient and their family in clinic. And I must admit, I'm not always great in that regard, and my recipient coordinator colleagues will sit there thinking, hold on, Chris, you don't talk about all this stuff. Is it because I'm scared? Is it because I don't want to talk to them about the risks of transmission of HIV, Hep B, Hep C, and cancer? It's not much fun to do that with a family of a 5-year-old child there. So it has to be done in the right way at the right time, and that's challenging to do. And of course, when in doubt, phone a friend. This is my favorite saying, prediction is very difficult, especially if it's about the future. Never a truer word spoken. But I think when we ask ourselves these really tough questions, I think we are missing opportunities now and again, and we need to be really stringent as a profession, as a clinical group, to make sure that we miss as few as possible. So in conclusion, yes, they're tough, but we need to acknowledge that we're probably declining some good quality deceased donor kidneys for the children on our list. We need to be aware of all those local and national factors and the data that could be out there to support our decision making. And always, if you can, as a transplant surgeon, as a transplant team, control the controllable. Have a short cold ischemic time, do a great operation, keep the warm ischemic time short, have wonderful nephrologists and nurses on the ward and in clinic to provide that aftercare that's so important, and work within what feels comfortable within your unit with gentle challenges now and again, and review all your organ offer decisions on a really regular basis. Thank you very much.
Thank you, Chris. Great presentation as always. Any questions? Professor.
When we talk about risk, it's trying to understand what the risk is. And people get fixated by, let's say, high-risk behavior, which is detailed and very specific for that donor. And yet, when there's no history available, it passes through without much comment. So I think it's how do we educate ourselves about real risk? Because actually for a child, HIV, Hep B, C is remarkably rare, and it would take a very narrow window of opportunity for the virus to come through to the child. So do you think living donor liver transplantation has done a kidney donation has done a disservice to the cadaveric side? Do you think it's made people very risk averse now?
We have a terrible problem in kidney transplantation in this country in that we have excellent outcomes, and it's a lovely problem to have. And we want those outcomes to be even better, but the margins are so fine now. I think in some ways, if you're a paediatric heart transplant surgeon or maybe liver or lung, and obviously you'll talk about that next, if you've got 5, 10, 20% rates of death on your waiting list, in some ways you're faced with such a stark difference. These things about increased infectious risk donors fade into insignificance. In the kidney world, I think sometimes we end up going round and round in circles and worrying about things which perhaps are not there quite so much. I think that risk is fundamentally about numbers, but even more importantly, it's fundamentally about psychology, and it's mainly about our psychology. We have psychologists to support our patients, and they do a great job. I wonder on occasion if we need to sit down with psychologists ourselves as a group and think, how do we perceive risk? What is it that we're trying to do? To answer your question, I think the success of living donor kidney transplantation has made it really hard for us. We see a deceased donor kidney transplant not so much as a failure, but certainly as a second best option. I don't think that's the case. I think we need to be hard-headed about risk and have some really honest conversations. We are very lucky in the UK. We don't have the problems they have in the US. We don't have 20% of our donors dying, after opioid overdoses or gunshot wounds. We're very fortunate, and I think we can be far more focused and hard-headed in that regard. Yeah.
Thanks, Chris, for an excellent talk. We're just about to look at the fourth time we've done a prospective audit of the declines in the UK, because what we found when we did it the last few times is that as soon as you tell nationally that you're actually doing the audit, the declined offers actually go down a bit in those years because people realise that the spotlight's on them. So I think there is a bit of clinician variability, and I think that, as you said, that now we're in the situation where if we've got a kid who's on the waiting list for a deceased donor transplant, that we're in the situation that maybe what our thresholds were 10 years ago are different. Maybe we shouldn't be so stringent on the matching. Maybe we shouldn't be so stringent on what we're aiming for, because if they are on the waiting list and it's gone up from kind of 250 days, like 265 days 10 years ago, and it's now heading from 1 to 2 years, we have to be careful.
And I think as a community, as I say, we need to get together and say, what is our standard approach to risk? We need to be having those tough discussions more. Yes, some of our donors will be intravenous drug users, but if their serology is negative, we can get a NAT test. If as a community we support that, then I think we should send that message, because otherwise it's the unsaid, it's the unknown, which I think makes it really tough for our children and young people and their carers, and makes it tough for us as well.
And my question to you was about hepatitis C, because it's actually now a treatable disease. So actually,
curable disease,
and it's curable. So actually,
Nigel's sitting there saying, "What are you worried about hepatitis C for?"
Well, I do worry about it.
Do you?
But it's because of the other viruses.
Exactly.
That come hand in hand with this. When you talk about risk, for me, the children who get split livers, the risk is with the other viruses, CMV and EBV, that happen early on in the post-transplant recovery, can influence both short and long-term survival.
Thank you very much.
Thank you, Chris.
Thank you very much. Thank you.